Good afternoon. It's a pleasure to welcome you to today's joint ESDS-ERS webinar on the interdisciplinary management of lung transplant recipients. It's a pleasure today that beyond the thoracic surgeons, we have great ERS faculty with us, and it's my pleasure to chair this webinar today with Federica Meloni, who's head of the ERS Assembly on Lung Transplantation and associate professor at the University of Padua and heading the lung transplant program there.
Thank you very much. I also thank ESDS for this very interesting initiative, and I am excited to be the co-chair of this meeting.
It's a pleasure that we have assembled a great faculty today, consisting of pulmonologists as well as thoracic surgeons, since it requires obviously a close collaboration between these two specialties in the management of recipients for lung transplantation. And we've have 4 interesting talks highlighting different areas where this interdisciplinary collaboration is of great importance. And we have today as the first speaker Peter Jaksch from my department at the Medical University of Vienna, who's the medical director of the lung transplant program. He will talk about the management of sensitized patients, and thereafter we have Alberto Benazzo, who is the surgical director of the lung transplant program within the department, and he will talk about the surgical evaluation of complex cases. So Federica, you want to introduce Andrea? And
yes, afterwards we will have a presentation, a talk from Andrea Mariscal, who is a thoracic surgeon, assistant professor of thoracic surgery from the University of Madrid, who will speak about new preservation strategies of donor organs for 10 minutes. And then we will have Michael Perch, who's the head of the lung transplant program at Riks Hospital in the University of Copenhagen, and he's also an officer of Assembly 8 in ERS, and he will speak us about the management of primary graft dysfunction. And then we will also have a very interesting 20 minutes Q&A session.
Yeah, as always, please ask your questions either in the chat tool or via the Q&A function, and as Federica outlined, we'll discuss them at the end. So Peter, it's your turn, and we're looking forward to your presentation on the management of sensitized patients.
Just a moment, I have to share. Does it work?
Yes, perfectly fine.
Okay. Yeah, good evening or good afternoon. It is a pleasure to be here and speak a little bit about sensitized patients. It's a quite complex topic, and mostly in most things we're not really clear how to manage these patients pre and post transplant. I think the first thing is to define what is sensitization. That means the patient has some antibodies. It could be pre and post transplant, and is detected by panel-reactive antibodies. And since the last 10 years, we have this new methods with a single antigen bead assays, which measure very exact the level of antibodies and for all classes. And it's very interesting because it's maybe sometimes it's too exact, and we sometimes do not exactly how to deal with this too much information. And one thing is that we know exactly that antibodies in any way, pre-transplant, post-transplant, are a risk for patients. They increase the risk after transplant for antibody-mediated rejection. They prolong patients on the waiting list because if you have a lot of antibodies, you maybe don't find a matching organ. And it also, after transplant, impacts on the long-term graft survival because you're getting acute rejection episodes and have a high incidence of getting chronic lung allograft dysfunction. Starting with the pre-transplant assessment, we of course just investigate all patients pre-transplant on the number of panel-reactive antibodies. That's some kind of screening method, and if these antibodies are positive, then we're looking for the specific DSAs using this single peat antigens. And then we can decide and make a risk stratification of these patients, how to deal with them on the waiting list. If the patient has no antibodies, we are very happy and say, okay, we can accept every organ for this patient, of course, except in donor size and the rest, but of course there's no antibody discussion. And if you have antibodies, we can, of course, depending on the number of antibodies and the type of antibodies, we can also look on a virtual cross-match pre-transplant to say this patient is maybe a candidate despite these antibodies, or we can say this is not a good candidate. And we can also stratify according to the number of PRAs. Depending on the center, you can say if some centers accept patients, if the PRAs are not higher than 50%, then you can accept them. Depending also now with this newer MFI measurements, we can now exactly measure the number and the type of DSAs, and then can say these antibodies are maybe acceptable. This patient could be accepted for transplantation. This donor could be accepted for transplantation or not, depending on the number and of the type of antibodies pre-transplant. We should make some kind of risk stratification before. This is a quite nice paper from Mr. Cartwright from, I think, from Boston. You see, this shows us the risk, which are the risk factors to get sensitized pre-transplant, and then depending on that, you can look on the MFIs, lower and higher MFIs pre-transplant, and then you can say this patient should be accepted or not accepted for transplantation. And if you accept him, because the patient is in an urgent status, we have to think about giving maybe some desensitization protocols that you can accept him despite having antibodies against the donor. But this is, of course, depending on the center experience. And there's a nice paper from Toronto. It was published 2020 about how the centers deal with patients with high PRAs or with antibodies. And you see about 20% say that have a clear contraindication if the patient have high PRAs. Means might higher than 50%, they wouldn't accept this recipient for transplantation. Or then some centers say that just looking on the antibodies at time of offer, and then depending on that, they decide if they take them or not. Some centers accept patients independent of antibodies and just looking for the cross match. And some centers like Toronto and also in Vienna, they treat sensitized patients on the waiting list, or maybe perioperative with some desensitization therapies. And these are the possible treatment options we have. Peri and perioperative, we can put them on plasmapheresis immunoadsorption and IVIG. We can combine this. We can put them on an antibody against B cells and anti-CD20 molecular antibody. We can put them on proteasome inhibitors, on complement inhibition, on photopheresis, and plasma cell antibodies. And this could also combine. But of course, the protocols are very different, and there was never any studies done to say, but this is the best way, and which is the timing, how is the efficacy, and how is the risk to get these patients treated with all these different strategies. And this is a quite nice diagram to see what in which level all these treatments interact with the immune system. You see, we can have directly treat the antibodies, we can treat the plasma cells, we can treat the B cells, we can treat in different ways, like using photopheresis, different immunomodulation to things on the whole system. Of course, this is depending, of course, on the experience of the centers, and also on the new drugs on the market, because maybe in the next years we get new drugs, and then we can also again try to treat these patients pre and perioperative. And there's one study from Toronto that looked on 340 patients and compared sensitized patients treated with a combination of plasma exchange, intravenous immunoglobulins, and ATG to reduce this burden of antibodies. And they compared this with patients without sensitization, with just PRA positive and DSA negative patients, and compared with DSA positive patients. You see, if you're using this protocol, the survival of these groups is more or less the same, and also the incidence of clot seems the same. That means it looks that this protocol in some way helps to reduce the burden of, or the risk to get acute antibody-mediated rejection after transplant, and makes an equal survival in all these three groups. So this is a study This is a protocol first from Toronto, and I think a lot of centers worldwide use this protocol. That's one thing about the peri and pre-transplant DSAs and immunization problems. Then we can say after transplant, if the patient survived the transplantation, we had no problems before, then we can say after transplant, we should in some way monitor if the patient develops afterwards some de novo antibodies. We should, therefore, in most centers, they have some protocols after transplant, making every week, and after then the first 2 or 3 months, then switching to monthly checks of the antibodies. And of course, if the antibody go up, then the question is what and how to treat these antibodies. And of course, if you have some acute antibody-mediated rejection with clinical symptoms, then of course we have to treat the patients. And this is also an issue because all these definitions of what is an ABMR, how is it defined, and how to treat them is also very different from center to center. And also the diagnostic yields are different because in Vienna, we see we have the last years we tried to have some not only the DSAs in the blood, but also using tissue DSAs from biopsies and also looking on cell-free DNA in blood and bile. But of course, it's some work in progress, and we just have at the moment just this very quite simple consensus of the ISHLT how to define ABMR. This is, I think everybody should know this. It's quite simple, just having clinical and subclinical ABMR with some different gradings. And then if you look on the details, we have this subclinical ABMR, which just have DSAs together with some unspecific things in the biopsy. That means it's not clear what is a subclinical ABMR because if you have DSAs, it's anyway, it's some kind of subclinical ABMR, but how to treat. And if you have clinical symptoms, then you have, of course, the clinic with some allograft dysfunction together with histology and DSAs and exclusion of other things, but also this is not very helpful in most cases because you can't make any studies with this grading system. Nevertheless, if you have an antibody-mediated rejection diagnosis, depending on what combination you have, then you have to treat the patient, of course. And the question is now, it is enough to just put them on plasmapheresis or give them some other treatments like rituximab, daratumumab, combine all these things. And of course, at the end, if you treat this patient, just our experience, we know that 50% of these really, if the patient has an antibody-mediated rejection with clinical symptoms, that the results are very worse than in cellular rejection because the most patients end up with glut or dying due to the diagnosis or the treatment afterwards. Therefore, it's at the moment frustrating and the results are not very convincing at the moment. Of course, this is one group, but normally we think about 3 to 5% of the patients develop some ABMR in the first year. The next step, if they don't have any ABMR after transplant, of course, they have maybe getting some DSAs, antibodies who could be transient or persistent, and also how to treat this patient, because we know if the patient has DSAs, there is a higher incidence of getting glut. Like if you have the patient on a higher level of immunosuppressive treatment because you think the DSA should be responding to higher cell doses or some, I don't know, then of course a higher risk of infectious. And of course, we are waiting for new drugs, hopefully to develop in the next week, or maybe new personalized medical treatment approaches to have some better control of these antibodies. And there's a quite nice study from our center. It was published last year just to say what happens if the patients have antibodies. You see, this is a group of patients we analyzed and differentiated between transient antibodies, means less than 3 months, and persistent antibodies against the donor. And if you look in this cohort, we had 400 patients screened. 50% of these patients developed some de novo DSAs, mostly in the first 1 or 2 years, and I think 75% had persistent or recurrent DSAs. And if you look on the survival rates, if the patient had a persistent DSAs, then the incidence of ABMR was higher than in the other group, with 20% versus 0, and also the incidence of glut after 2 and 3 years was different in the group with persistent versus transient DSAs. That means if you have persistent DSAs, in some way you should treat them, but we don't know exactly how to treat them. Some centers put this patient on some immunoglobulin treatment for 6 months. In our center, we just started right now a study using photophoresis after 3 months of persistence of DSAs, then put him on 6 months photophoresis to see if maybe this may have some benefit on the course of the DSAs and of the course of the disease of her clot or ABMR. I think it's also some work in progress, and hopefully in the next years we get some answers. Yeah, to summarize, we can say pre-transplant we should in some way judge the risk of sensitized patients and maybe treat them. Peri-transplant we should of course look on the best matching donor and making some cross matching. Post-transplant we should monitor the patients in the quite narrow windows in the first months and make an early intervention if they have DSAs or getting some signs of ABMR. And in the future, maybe we should have some better desensitization programs and ABMR management. And this is maybe one idea that we can maybe combine all these treatments together using depleting or treatments like anti-CD20, CD38 or CD52 together with with a removal of antibodies and together with a maintenance treatment of co-stimulation blockade with belatacept or IVIG in combination. Okay, thank you for the attention.
Thank you, Peter, for this excellent overview on the management of sensitized patients. Frequently, we are also confronted with complex surgical situations and decisions, and Alberto will give us an overview on that now.
Yes, thank you very much. I hope now the presentation is online. Thank you for the invitation. Since it is quite a complex topic, I decided to pick out the three complex scenarios that we can encounter in our routine practice. Obviously, there are some rarer patients than the classical COPD or IPF patients. But for these reasons requires probably a little bit more complex evaluation from both surgical and medical point of view. So let's start from the first, which is the pulmonary artery aneurysm. Pulmonary artery aneurysm is defined as a main PA diameter of more than 40 millimeters. It has been found in approximately 1 out of 14,000 autopsy studies. And in the majority of the cases, is associated with congenital heart defects, but also PH. Approximately, therefore, we have an incidence of 4 to 10%, and it is quite a dangerous situation because it is associated to dissection and rupture of the pulmonary artery aneurysm. The pulmonary artery aneurysm is defined by a progressive dilatations independent of PA pressures. This is a CT scans of one of our patients. As you can see in panel A, the initial findings were 45 millimeters, quite common in a PAH patients, and 8 years later it was twice as big. So coming to the evaluation of this case, it is important to offer to these patients quite fast lung transplantation. First of all, obviously to replace severely diseased PAH lungs, but most importantly, irrespective from the PAH treatment stages that the patients are, to correct this life-threatening pulmonary artery aneurysm. In this case, it is important to know that due to the compressions of the PEA, patients might require coronary stenting of the left coronary artery. It is important to assess the competence of the PEA valve. Some minimal regurgitation is acceptable, but the PEA valve should be competent. And third point, which is very important in the management of these patients and in the decision during the donor acceptance, these patients require a donor with a heart unsuitable for transplantations, as we need the entire pulmonary trunk for reconstructions. So going through the surgical procedures, the lungs are explanted in the classical way, but the whole pulmonary artery is retrieved, and the right and the left lung are divided at the level of the left branch, so that we have the full main trunk of the PA. This is intraoperative photos. As you can see, you have the SVC and the aorta, and then these huge pulmonary artery aneurysm. After opening of the clamshells, we need the cardiopulmonary bypass with bicaval cannulation, and then we proceed with explantation of both lungs. You can use a flexible venting in the PEA for better exposures, and it is important to have to transect the main PEA supravalvular. Then the first implanted side is the right side. Obviously, after creating a channel below the SVC and the aorta, it is important to bring the whole pulmonary artery below it, and the anastomosis is between the main PA of the donor and the supravalvular rim of the pulmonary valve. And then you proceed with the implantation of the left side, which is basically in a classical fashion. This is one photos of one of our patients. As you can see, after post-transplant, there was obviously full normalization, and the patients didn't require, therefore, heart transplant. The second scenario that I think it's important to mention in the complex cases is the retransplantation for CLAD. Retransplantations is probably the only real, let's say, therapeutic option for end-stage CLAD, as the treatment that are available are not curative. Only 5% of the transplantation per year worldwide are actually retransplantation, which means that only high volume centers have really real experience, and also in those high volume centers, retransplant patients count really as a few patients. It is a highly challenging procedures, and it is important to mention that there are challenging situations in the perioperative period, but also challenging factors in the long-term follow-up. Unfortunately, due to this limited number of cases, it is very difficult still to understand which are the factors preoperatively that can tell us whether the patients can be successfully transplanted and then followed up or not. I think it is when we speak about retransplantation for CLAD, it is absolutely important to mention this seminal work from Leuven, Duke, Toronto, and Hannover. It was published in 2015, so before the last CLAD consensus. I think this is till now the largest study published until now, including 143 retransplant for CLAD. And since the guidelines or the consensus, the CLAD consensus was still the former one, they diagnosed or divided patients in BOS and restrictive CLAD. It is very important because it was they were able to show that patients with restrictive CLAD had significantly lower survival, and as you can see, I think the steepest decrease in survival or the highest mortality was in the perioperative period, and this is something that we have observed as well in our experience. A second important work is from UNOS database, where they analyzed the results of retransplantations in centers based on volume. And as you can see, it is clear that the centers with the low volumes has the worst outcomes in these very complex patients. In order to understand what was our outcomes in our centers, we looked at our patients, and we published this last work the end of last year. It was a single center experience from our centers, including 70 retransplant in approximately 20 years period. And we divided the patients in BOS and non-BOS. As you clearly see also in our series, the restricted patients represented the minority. It was interesting to see here that the patients with belonging in the non-BOS group had the higher level of DSA and higher incidence of AMR before retransplantations. And obviously, which was basically our main focus, the thoracic cavity was definitely smaller in the restrictive patients. So based on that and based on the international experience, it is we looked specifically in our RAS patients, and we couldn't really find any evidence or any parameters telling us which RAS patients are safe to transplant and which are not safe to transplant. As you can see here, two cases. On the left side, this young lady received double retransplantation for RAS. Obviously, quite a complex postoperative course, but could be discharged after 45 days. On the right side, this patient received a single retransplant and had a very dramatic postoperative course, and she died at postoperative day 9th. The CT scans didn't tell us much, and the chest cavity was quite similar between both of them. So again, there is no evidence to guide us in the choice of these patients. Is very important that these patients are transplanted in high volume centers. So exactly for this concept or for this issue, we looked at the postoperative and perioperative factors in these patients. We didn't find any different in the intraoperative need for blood products, but in the postoperative period, you can see that the patients in the RAS and mixed group required a higher level or higher amount of frozen plasma and fibrinogen, indicating a higher rate of bleeding postoperatively. The PGD2 and PGD3 were slightly higher in the non-BOS group, as you can see on the left side, but this didn't turn in a worse survival in the long term. However, when we looked at the subgroup analysis, we identified in our group that patients who required an ECLS bridge to retransplant, as well as older patients, so more than 60 years old, as well as patients that required a retransplantation within 1 year after the primary retransplantation, had dramatic outcomes. Based on these findings, now our evaluations of these patients is very selective. So patients obviously need to have acceptance criteria for any lung transplantation, but they need to be younger than 60 years old. They need to be in a good physical conditions and psychological conditions. normal kidney and liver functions, they need to be at least more than 12 months after a primary transplantations. And for RAS and mixed phenotypes that were associated with higher postoperative bleeding, we tend not to put them on preoperative ECMO. Instead, we prefer to list them early in the disease so that we can avoid decompensations. And the last cases is lung transplant for ARDS. There I started with the first cases, a 6-year-old girl in 2019 with ARDS pneumonia. The initial request for lung transplant in Vienna was declined because of sepsis, and there went different ECMO strategies. And then after stabilizing the patients and resolving of the sepsis, she was transferred to Vienna and listed for transplant. She arrived with a central ECMO with completely hepatized lungs and the dramatic signs of this disease course. So the patients after transfer to Vienna was listed, underwent bilobal transplantations, require prolonged central ECMO. Then we downgrade the central ECMO to a single cannula VV ECMO, and after a few months of postoperative course, was discharged, and now she is doing fine at home. The second case is another lady, 34 years old, female, with an influenza ARDS on the 14th week of pregnancy. On the 12th of February, back then was intubated and required VV, and on the 1st of March was transferred to our center. This was the status at admission in our center, so required very intensive respiratory effort, high flow of ECMO with low oxygenations, was otherwise healthy, normal kidney and liver functions, and the fetus had a normal development. So at that point, we had in the surgical evaluation or the transplant evaluation, two main questions, whether one from the side of the mother, where we continue on the same therapeutic strategy or we offer lung transplant. And the other was on the side of the fetus, whether we needed to interrupt the pregnancy under ECMO support or to continue the pregnancy after transplantation. We decided to list the patient to lung transplant and continue the pregnancy. This was the clinical situations when we listed the patient on VV ECMO. The patient had a loss of 33, exceptional loss was declined. At the end, we got an organ which was quite good actually, with 480 PF ratio. On the postoperative day 1, the patient came out from the OR with a prolonged VA ECMO. On the third day, we removed the VA ECMO and we weaned the patient. The fetus was normal and the placenta was well perfused. This is an echo in the first days after ECMO removal. The fetus the patient underwent the section and the 32nd pregnancy week, and the patient unfortunately the fetus unfortunately died due to the respiratory insufficiency. So based on these two ARDS cases and on our experience, I think it is very important in the evaluation of these patients to catch the best time point when we can list these patients. We know that most of the patients with ARDS recover within the first 4 weeks. As you can see in this ELSO database analyzes, the patients on ECLS dramatically decreased within the first months, and the patients discharged alive remained around 50%. So it is important to get the best time points in these patients. Also because it is well known based on the experience after COVID and over the last 5 to 10 years that patients undergoing lung transplant in an acute phase of RDS are at very high risk, while lung transplantation in a late course of RDS disease is a more low risk transplantation. The second important thing is candidate selections. BMI for us plays a very important role in these patients, and frailty and biological age is a third important factors. As you can see, these are two photos of two patients in our outpatient clinic pre-transplant. The patient on the right side definitely had not a good rehabilitation potential compared to the other patient. So when to consider lung transplant for RDS? Based on the experience on the last years, we consider lung transplant for these patients if patients are younger than 65 years old, have only one single organ dysfunctions. They need at least 4 to 6 weeks on after initial clinical signs of respiratory failure. There need to be a radiological evidence of irreversible lung disease. The patient should be awake and perform rehabilitations while waiting for an organ. Obviously, the patients need to fulfill typical criteria for transplantation, and it is important that the center listing these patients have enough experience with ECMO bridging, but also access to a broad donor pool and a low waiting list mortality. Thank you very much.
Yeah, thank you, Alberto, for this nice overview on 3 specific topics. And I'm handing over to Federica.
Thank you. Thank you. I would, first of all, I would like to remind you to send your questions in the Q&A section, because at the moment there are no questions, and it's really a pity not to have a very interactive discussion. And then we are going to the next talk from Professor Mariscal, Andrea Mariscal from Madrid. She will speak us about how did we improve in the management of the lung before transplantation, the preservation of the lung. Thank you.
Hi, do you see my screen?
Yes.
Can you see my screen?
Yes, we do. Yes.
Great, thank you. Thank you for inviting me to give this talk. So to start and talk about the new procedures, we need to talk about how we started and how we got into where we are now. So we know that lung transplantation has become a very well accepted treatment for carefully selected patients with terminal respiratory diseases. However, it took several decades of experiments to get into the point where we're at now. And the journey began with 2 very significant milestones. In 1982, the Stanford group achieved the first successful heart-lung transplantation. And then 4 years later, the Toronto group reported the first transplant on the New England Journal of Transplantation. So over time, the methods and techniques for donor lung preservation have significantly evolved. So the first, at the beginning, the Toronto group, what they did is they used simple hyperthermic immersion of the collapsed pulmonary graft. And that in the early days was what they used, but obtaining lung preservation for extended period of time with just topical cooling alone was very challenging. So in 1987, Hardest and Griffin introduced what's called the autoperfusion by normothermic machine preservation of the heart and lung, and they could achieve some more distance procurement. And this technique involved flushing with urocolin solution for a few minutes. And that was a method that was rapidly adopted by most of the transplant centers to have more distant procurement of heart and lungs. Today, the vast majority of transplant centers use a single pulmonary artery flush combined with topical cooling of the lungs. So preservation solutions can be intracellular or extracellular. The intracellular, as we all know, are the Wisconsin and the urocolins, and what they have is high potassium, and that means that they prevent sodium from penetrating the cells. They also include the high molecular weight substances that cannot pass through the cell membrane, and that increases the extracellular osmotic pressure. But during the late 80s and 90s, what they were using were the modified urocolin solution. They were using also for the abdominal transplant, which is a crystalloid containing high potassium, and that was the standard of care for lungs and abdominal. There were other centers that were using the Wisconsin solution, or even another solution, which is a colloid with donor-based blood. This led to a significant shift towards more extracellular type solutions, which is what we're using now. Those solutions have low potassium and high sodium. LPDG is the only solution specifically developed for lungs. And the initial concept of using this extracellular solution for lungs was presented by Fujimura, and then Keshafi from the Toronto group published improving that solution with the addition of dextran 40, acting as an osmotic agent. And then a little bit later date suggested supplementing the low potassium dextran solution with glucose to sustain the aerobic metabolism of the lungs and conserve the cellular integrity. The other solution that has been used is the Celsior that contains other antioxidants, and that is supposed to help prevent injury. So there are several drugs that are being studied currently, and for their potential benefits in lung preservation being added to the perfuset. One of them is alpha-1 antitrypsin, raffinose, glutamine, other nutrients and drugs. So a lot of researchers are exploring the addition of all these nutrients and preservations, amino acids, vitamins, other cryoprotective biochemicals. So all these studies are being focused on enhancing the cell protection and improving the lung preservation outcomes. There's another solution from the Japanese group called ET Kyoto solution. And this is an extracellular type solution and containing 3 components: acetylcysteine, nitroglycerin, and adenosine cyclic monophosphate. This solution is widely used in Japan, and there are some promising clinical results of lung that can achieve longer cold storage prolongation times using it. So, but what's the cornerstone of organ preservation was the static cold preservation that for many years. So the primary goal of the static cold preservation is to slow down the metabolism, reduce consumption of oxygen and other substrates, and that's in an attempt to prevent organ deterioration. And this strategy, what it does is reduces the cellular activity, but it is in a non-selective manner. So it includes processes that lead to edema and cell damage, but it can also include processes that we don't want to reduce. So by understanding all these principles, that's how we started seeing some advancements in the current techniques that we're using now. So this is a slide that summarizes the current practice in lung preservation. We use a low potassium dextran solution, and that's widely adopted in lung preservation. This solution has proven to be effective in maintaining normal pulmonary artery pressure and preserving endothelial epithelial barrier. Most of the centers do retrograde flushing during lung preservation. That has also demonstrated to be beneficial by improving the distribution of the flush to the vascular beds, and can also potentially remove some clots from the pulmonary circulation. We also agree on inflating the lungs to keep us oxygenated in ischemia. And that's keeping the lungs with oxygen during the cold ischemic period, and that has shown to be beneficial in a lot of studies. So it preserves aerobic metabolism, the epithelial fluid transport, and the integrity of the surfactant. On the other hand, we need to be careful. We know hyperinflation of the lungs is detrimental. Overinflation can cause barotrauma and increase pulmonary capillary filtration coefficient. we have to make sure that we don't have atelectasis, because we know atelectasis leads to higher pulmonary vascular resistance. So this is one of the new studies that we are seeing is lung cryopreservation, and it involves storing the lungs in a sub-zero temperatures for potentially banking organs. It is a bit challenging. Freezing and rewarming in the lungs especially can cause alveolar damage and even ice growth inside and outside the cells. There's a study by Lautner and colleagues that have used ice recrystallization inhibitor, and they froze the lungs at -5 degrees per minute until reaching -20, and then following by a low temperature fixative. So this method reduced the ice grain size and improved post-thaw cell membrane integrity, but we're still far from being able to use it in a clinical setting. So this is what changed preservation a few years ago. This is ex vivo lung perfusion that offers a lot of advantage over static cold preservation. It allows evaluation and treatment of donor lungs before transplantation. So Steen started it in the 2000, using it just to evaluate lung suitability in the DCD lungs. And then later in 2008, Seipel and the Toronto group successfully performed prolonged normothermic EVLP. And their protocol became the standard for many centers, not all of them, but many. And there have been a lot of research demonstrating that 12 hours normothermic EVLP can improve lungs, diminish edema, even epithelial and tight juncture integrity, maintaining metabolic function. And so for EVLP, the most common indication is reassessment of marginal lungs, and that's running EVLP between 3 to 6 hours. We have also seen some portable EVLP machines that can be used to prolong preservation of healthy lungs for logistical reasons, allowing for longer distance travel, facilitating combined organ transplantation. One of the key advantages of EVLP is that it can assess and improve the suitability of the graft before transplantation. And that's very important, since we know that only 15 to 20% of the lungs from multi-organ donors are used for lungs. So 85% are being rejected due to some concerns. During EVLP, we can continuously monitor, evaluate the trends of airway pressure, compliance, assess the oxygenation, cytokines, evaluate with X-ray the edema, and many reports have described the ability of EVLP to recondition lung graft prior transplantation by removing airway secretions, recruiting, resolving some of the edema, and even washing out some immunological cells. So successfully reconditioning marginal lungs with a clinical setting can also be achieved and have been demonstrated by several studies. So what's the optimal preservation temperature for lung transplantation? So preliminary studies over 30 years ago suggested that 10 degrees was the optimal storage temperature. However, translating these findings to clinical practice never occurred due to two main things. One were some concerns over the safety and the limited biological information, but there's also the challenge of keeping the lungs at that temperature and measuring that they are actually at that temperature. Ice was very simple and reproducible. We thought we were maintaining lungs at around 4 degrees, but some studies have realized that we were conserving the lungs under 4, closer to 0. And then in 2021, the Toronto group revisited the concept of which was the optimal temperature that we will be needed to use, and they compared the performance of big lungs in the ex vivo lung perfusion platform after 36 hours of 4 degrees versus 10 degrees of static cold storage. And the functional evaluation showed better outcomes for grafts that were stored at 10 degrees. So the mitochondrial metabolites show protective profile at 10 degrees. They were linked at better response of ischemia perfusion injury, and all this led to a preclinical study for a proof of concept trial with the first 5 patients included, using 10 degrees as the target temperature for lung preservation to prolong the cold ischemic time, making so that made lung transplantation more flexible. So currently there's this clinical prospective multi-center trial with 19 centers, including our center. And the results so far are promising and have shown similar, if not better, outcomes in the group that is with 10 degrees. So one of the great advances within the field of organ transplantation has been the ability to preserve organs prior to the time of implantation. Initially, transplant operations required the donor and the recipient to be in side to side in the OR to avoid any ischemic organ damage. Then that was the big development of the cold storage that allowed donor lungs preservation with an average of 4 to 6 hours worldwide. And that improved the logistics of donor organ transportation. However, extending over more than 6, 8, up to 12 hours was generally discouraged due to the fear that the patients will develop primary graft dysfunction that we know is responsible for early mortality within the transplant recipients. After that, EVLP emerged as a very valuable assessment and potential treatment platform that changed lung transplantation and was able to prolong times. And now maintaining lungs at 10 degrees for a longer period of time is allowing us to avoid overnight transplantation and potentially overcome geographical constraints in organ donation. It's desirable to be able to even maintain the organs for longer time so we can optimize the immunological matching among donors and recipients and really transform lung transplantation into a semi-elective procedure the way we are doing it a little bit now. So if the preservation of could be, if that long preservation, like days, could be achieved, that will enable us to have some more time-dependent pre-transplant therapies and actually improving the success rate and the outcomes of lung transplantation. Thank you.
Thank you. Thank you very much. This has been really very exhaustive. And I will, it's a privilege to introduce the last speaker of this evening, Professor Michael Perch, who's going to go on with the journey of lung transplantation, speak us about primary graft dysfunction.
Thank you very much, Federica. I will just need to get this running.
Presentation mode.
Here we go.
Thanks. Fantastic.
Good. So thank you very much for inviting me to do this presentation on primary graft dysfunction in lung transplantation. As the final speaker, I can see that time is limited, and I will see if I can catch up a little bit here. These are my disclosures. So the total number of lung transplantations are increasing worldwide, but primary graft dysfunction continues to be a significant source of both short and long-term morbidity and mortality. This is a publication or a statement from a publication back in 2015, and I think it's still the case. Lung transplantation is a life-saving procedure for the majority of patients offered a transplantation with end-stage lung disease, but PGD continues to be something which can affect the outcomes, and it is something which is seen very early after transplantation. So this presentation is supposed to cover pathophysiology, risk factors, the diagnosis, and how to manage PGD. As I mentioned, PGD significantly impacts early morbidity and mortality. This was described by one of my colleagues back in 2007 looking at radiologic infiltrates within 72 hours after transplantation. And as you can see on the upper graph here, having radiological infiltrates did impact the overall survival of this population. And if you looked into the severity of the infiltrates, you can see the more severe, the more impact on long-term survival. Probably not that surprising, but still an important finding. Also, we know that PGD has a higher incidence of developing chronic lung allograft dysfunction, or maybe even what we nowadays call baseline lung allograft dysfunction, meaning that the development of lung function after the transplant procedure never really exceeds more than 50 to 70% after transplantation. So what's the definition of PGD? This is the consensus statement from the ISHLT, which was dated back to 2017. And there needs to be pulmonary opacities on thoracic imaging and hypoxemia without any other identifiable cause. And it's developing within the first 72 hours after the lung allograft implantation. So a quite crude definition, but is used worldwide for sort of describing this this state. It's been many hypotheses has been thrown out to what's the reason for PGD, and it's probably a combination of multiple factors which influence the development of PGD, also called ischemia reperfusion injury, which leads to inflammation and the damage of the endothelia in the lung, which again can lead to neutrophil activation and cytokine release, which contributes to vascular permeability and results in the pulmonary edema, the impaired gas exchange, and the hypoxia of the tissue, which again can worsen the whole procedure here. These are two different depictions of where the edema can be localized, and in the upper part you can see the interstitial edema increasing the thickness of the wall, and in the alveolar edema it's more the alveolar which gets flooded with fluids, compromising the gas exchange. If you look at a pathology or histological biopsies, you will see, you will most often find some sort of diffuse alveolar damage, approximately in 30% of the cases. This is characterized by hyaline membranes in the acute stage, which can lead to alveolar septal thickening by increasing number of fibroblasts, which also compromises the gas exchange. Here's an example of a single lung transplant recipient on the left side, where you can see the edema in the lung, and on the left side a specimen where you can see the DAD with the hyaline membranes shown by the arrows. So PGD is the result of multiple injuries to the lung grafts, which starts already in the organ donor and lasts during and after implantation. And if we improve our understanding of these mechanisms that cause PGD, we will have more options of intervening in these processes and improve the outcomes after lung transplantation. Here you see a table of different risk factors, and they can be related to the donor. They can also be acquired by the donor. They can be related to the recipient, and they can be related to different operative variables during the transplant procedure. I won't go into detail, but you can see there are many different risk factors for developing PGD. This is something similar here with risk factors related to donor, related to handling of the donor organs, reperfusion, and recipient or operative factors, all leading to PGD. So the clinical presentation is increased dyspnea due to hypoxemia or increased ventilatory requirements. And the diagnostic criteria, as mentioned before, was the presence of radiologic opacities. The PGD can be graded from 0 to 3 based on the PaO2/FiO2 ratio and the radiographic findings, as you can see here. So the radiographic findings can be mild or severe, but the grading of the PGD is based on the PaO2/FiO2 ratio. And of course, you have to rule out other causes like infection or rejection or embolisms. Here are some examples of different radiologic findings and related to PGD grade, which is, of course, based on the hypoxemia. Here are some other findings. So how do we manage these PGD patients? Mainly it's based on supportive care, like mechanical ventilation, if that's needed, with lung protective strategies like low tidal volume or PEEP. There's the possibility of using extracorporeal membrane oxygenation or ECMO as either prophylaxis or as a treatment, but mostly in severe cases. Fluid management, keeping the patients dry to avoid worsening the edema, and also pharmacologic therapies like inhaled nitric oxide, prostacyclins to improve the oxygenation. But again, trying to prevent the development of PGD by optimizing the donor, the recipient selection, and minimizing ischemic time. Originally, I wanted to say a couple of words about the use of ECMO. This is from a publication from our American colleagues, and the use of ECMO either depending on previous or existing pH as a prophylaxis, or using ECMO post-operatively, depending on the oxygenation of the patient. But due to time restraints, I will quickly move on and not go into detail here. Future directions for handling and managing PGD, could be novel therapies targeting the inflammation and endothelial dysfunction. For example, the possibility of using stem cell therapy has been suggested. Machine perfusion of donor lungs to reduce the ischemia reperfusion injury, and also the need for improved biomarkers for making this diagnosis early and target interventions. So in conclusion, PGD is a serious complication for lung transplantation, which requires prompt recognition and management. Supportive strategies and ECMO play a key role in treatment and management, but ongoing research aims to improve prevention and therapeutic approaches. That was my presentation, and I will be open for questions.
Thank you, Michael. I really thank you because you were rushing and tried to save time, so it was really, really good. So, Professor Clemens, what do you think? Do we still have time for questions?
Yeah, we're already a little over time. I think we can do brief discussions. So if there are any burning questions, please put them in the chat. So maybe I start with a brief question for Andrea regarding preservation. So how long can we currently go with our preservation strategies, and can we combine them? Can we like do EVLP, put the lungs on 10 degree afterwards? And so what do you think is the current maximum we should go for?
So we don't have a specific number of hours. We know there are a few reports from Toronto and Vienna doing preservation at 10 degrees for over 24 hours. So we know that has been safe. I wouldn't go that far if possible. We have done it in Toronto and Vienna with good results. And then, so then the next step is the intermittent 10 degrees EVLP and then 10 degrees EVLP. So Toronto does that. They have gone also up to a day, but ideally it will be to go to 3 days so we can actually treat the lungs while on EVLP. So we haven't been able to achieve that clinically, but that's what everything is moving towards. So I think we should be safe to say that 20 hours seems to be okay, plus or minus putting some EVLPs there. Toronto is doing those studies, so I guess we'll know soon if the intermittent EVLP between 10 and 10 EVLP, 10 EVLP is actually achievable and how long we can go for.
I possibly have one question for Peter and another for Alberto. The first one is, Peter, you mentioned ECP. I didn't understand why you would like to include ECP in the management of desensitization before transplantation, because I always thought that ECP is too slow and it's something that we should use as a consequently after anti-B cell target therapy. And to Alberto, I would like to ask you, how did you manage immunosuppression in redo patients? How did you manage the induction in particular?
Okay, then the first question for me, I think it's pre-transplant, it's right. This makes no sense. We tried it in, I think, 6 patients on the waiting list that didn't work, but we can use it in a peri-operative setting. If the patient is desensitized perioperative, they can, after maybe giving some immunoabsorption or daratumumab, we can afterwards to have some kind of rebound prophylactic treatment after transplantation.
Okay, thank you.
Thank you for the question. I think the main important thing is to understand or to know how long is from the primary transplant. So if the patient are very short from a primary transplant, since our primary induction therapy is alemtuzumab, then we tend not to give alemtuzumab a second time. On the other side, patients that are long-term of a long-term clad and are long-term after the primary transplant, they have no problem anymore. The effect of alemtuzumab is already gone. As we know, the effect of alemtuzumab is maximum 24 months. So if they are long after the primary transplantation, a second shot of alemtuzumab would not be contraindicated.
Thank you.
Thank you. So, Michael, if you're faced with an infiltrate in the lung, say 4 or 5 days after transplantation, how is your strategy to differentiate between a delayed PGD and some early immune?
Oh, I think that's a very good question, Clemens. First of all, PGD would be defined by hypoxemia. So having an infiltrate doesn't necessarily mean that much. But of course, it depends on the state of the patient, and I think 4 to 5 days after transplantation, I would be more relaxed and see how things evolve, but try to be upfront and avoid, look for infections, look for other things which can cause an infiltrate.
Okay, yeah, thanks a lot. So
We have one question from the audience. Are there currently any studies that can show the right way for the future? Very, very wide question. So who would like to answer to this question? I think everybody could say his thought.
Do you mean within lung transplantation or just in general?
Maybe in another setting. Let's restrict it to the lung transplant setting.
So I think that's probably a question we can base our next webinar on.
Yeah. Next, many webinars.
Yeah, I think there's probably not one study which can tell us where the future goes, but I think that in lung transplantation, we have to try and optimize every step of the procedure. And so doing research within every step from, donor care to long-term immunosuppression needs to be optimized all the way to try to improve the outcomes after lung transplantation.
And this also highlights the need for multidisciplinary approach again. So
Yeah, thanks a lot. I think that's a very good final word since we're already over time. We have to close for today. I'd really like to thank all of you for the excellent presentations, the participants for joining us, and yeah, Federica for moderating with the ARL. So the webinar can be replayed as usual on the ESDS homepage, and we will also make it accessible for ERS, of course. And I would also like to invite you to join our next webinar, which will take place on March 10th and will be focused on AI in thoracic surgery. Thanks a lot for today, and see you next time.
Goodbye.
Thank you.
Thank you.
Thank you.